Thank you very much, guys. Thank you. Thank you. So, shall we start? Perfect. So today we are not going live on YouTube right now because I think we have the capacity of 1,000 participants in Zoom, and only joinees are less than 200. There are 800 students right now, 834 students in this course, but only 127 are joining. That's okay. They all are comfortable with the recording, so that's okay. Let us start. Let me start the class, guys. So in last class, we have discussed heart failure, right? Heart failure pathogenesis, heart failure types, heart failure classification, classification of symptoms, signs, and classification of severity, NYHA class, treatment, treatment pattern, treatment algorithms, about implantations, and multiple more things. We have discussed around around everything of which is related to heart failure. So today I'll be continuing that. So there is very important thing which is remaining, and that is medication compliance in heart failure, and what patient has to take care about at home after getting heart failure. That's very important. Okay, and what are the counseling points for the pharmacist or for the doctors, for the nurses, for the healthcare professionals to tell to the heart failure patient? Okay, those are very important things. And what are the precautions heart failure patient must take at the home? Okay, so these are the things what we really need to discuss. And along with that, today's session is going to be very much interactive. I want all of you to unmute yourself whenever it's needed, okay, and answer and talk to me, discuss with me, because I'm going to discuss a case today. Everything will be discussing through a case. Okay, so I'll be starting with a case, and you all have to tell me. And guys, we have 1.5 hours to discuss this case, along with the points, along with the precautions, along with the patient counseling, and even the caregivers counseling. Whatever is needed, I'll tell you all the points, whatever we experience, whatever we do, whatever I do in my practice with heart failure patients. I'll tell you everything. Okay, so let's start. Let me share with the let me share the slides with you guys. Okay, before that, I think before going to that, I think someone has asked me last time about SGLT2 inhibitors, sodium glucose co-transporters inhibitors. Okay, so definitely, these are the new promising drugs. These dapagliflozin, canagliflozin, and empagliflozin, which are really good for the heart failure patients. Also, mainly dapagliflozin and empagliflozin are really good for the heart failure patients. These are the two drugs which are really giving the promising results, and nowadays they are considering to the upper level of choice of the drugs, like first choice or second choice of the drugs, these sodium glucose co-transporter 2 SGLT2 inhibitors. We call them SGLT2 inhibitors. Why and how they actually work? So that what exactly SGLT2 inhibitors work in diabetic patients. They are differently working, but in heart failure patients they definitely increase the mitochondrial calcium levels, and they reduce the cytoplasmic sodium and calcium. How? Because they actually downgrade the sodium and water exchanger. Okay, sodium and water exchanger in proximal tubule in the kidney, and they enhance the sodium excretion. They promote the sodium excretion through the natriuresis process. They enhance the sodium excretion in the urine and reduce the the fluid overload. Okay, that's how SGLT2 inhibitors work in the heart failure and reduce the heart failure symptoms in the patients and improve the patients. Okay, so I hope my slides are visible to all of you. Okay, let me. Oh, visible, guys, please reply. Okay, thank you, Tanya. Thank you very much.
Yes,
Great. Okay, so let's start with the case. That would be great. So as usual, this case is solely prepared for the educational purposes for the students using a real-time MI case with full anonymity of the patient. Okay, this is an MI case, myocardial infarction case primarily, but a heart failure patient also. Okay, and now we have to discuss this, and you have to find out all the possibilities, whatever are required. Okay, so let's discuss the case. Let me go to the first slide. What we are going to discuss, we're going to discuss the case, entire case, along with the diagnosis, final diagnosis, provisional diagnosis, and differential diagnosis, treatment algorithm, GDMT, whatever is there, prescription audit, discharge plans, and patient counseling, importantly. Okay, so this is the case, guys, in front of you. This is the case today. So this is a case of a 68-year-old man who was admitted to the emergency department complaining of increasing shortness of breath. Okay, breathlessness, or we call it dyspnea also. So shortness of breath. He was woken on each of the last 2 nights, struggling for breath in the night. He has woken on last 2 nights. Okay, so I told guys, please unmute yourself when it is needed, whenever I ask questions or you have any question. So everyone has to mute yourself otherwise. So he had the problems on arrival at hospital and on subsequent examinations and review by the admitting doctor. The following information is obtained. So what was the observation? Shortness of breath and tiredness increasing over the last 2 months, and the patient is able to walk approximately 20 meters in one go. Okay, so can you tell me what are the typical symptoms of heart failure you find here? Can you please tell me what are the typical symptoms of heart failure you find here?
Shortness of breath,
breathlessness, ankle swelling, fatigue.
Okay, breathlessness and fatigue. Great. Okay, and anyone else?
Pulmonary cracks, peripheral edema, ankle swelling.
peripheral edema.
Peripheral edema. Peripheral edema. Are you serious, guys?
Pedal edema.
Where pedal edema?
Dyspnea.
Where is the pedal edema here
In
this
this
slide?
case, only 2 things are given, like shortness of breath and tiredness only.
Yes, there is no breath, there is no pedal edema at all. I did not say pedal edema. There is nothing.
They are telling the total symptoms of the heart failure, not about this case only.
I'm telling about this case. What do you feel? What are the typical symptoms of heart failure here? You find out.
Shortness of breathing.
Okay, shortness of breath and
Fatigue.
fatigue.
Able to talk.
Dyspnea.
Don't you think there is one more?
So nocturnal dyspnea.
Exactly.
Distance travel
PND.
also.
Exactly. PND. Proximal nocturnal dyspnea. It is clearly mentioned here. Let me start my presenter view pointer. Yeah. So see, he has woken on each of the last 2 nights struggling for breath. PND, this is actually not PND. This is not actually nocturnal dyspnea. This is orthopnea while sleeping. Okay, this is not exactly PND. That's not proximal. That is orthopnea. Okay, ORTHO. Okay, PNEA, orthopnea. Okay, this is orthopnea, and this is another typical symptom along with here fatigue and breathlessness. Okay, next thing, past medical history: ischemic heart disease over 10 years with recent MI 18 months before, and hypertension for 10 years. Social history: a patient is a regular cigarette smoker, more than 30 per day, and drinks approximately 35 units of alcohol per week. More than 30 cigarettes per day, and chronic alcoholic, 35 units of alcohol per week. No family history of cardiovascular disease. Now, sign and symptoms when the doctor have checked him. Sign and symptoms of examination. Patient was pale on examination. So what does it sign?
Lack of blood supply, sir.
Okay.
And
What is
anemia also.
anemia? Exactly. This is anemia. This is symptom of anemia. Temperature normal, blood pressure a little lower, heartbeat 90, regular, that's okay. Swelling of ankles. Here it is. Here it is pedal edema. Okay. Pedal edema is not a symptom. Pedal edema is a sign. Guys, remember this. There is a huge difference between symptoms and sign. Objective and subjective. Remember, objective and subjective. So what is objective? What is subjective? Anyone? Okay.
Subjective is the complaints of patient.
Yes, sir. Objective is the laboratory report and so on.
And physical examination.
Regarding the patient's condition.
And what is subjective?
Subject is the complaints.
Chief complaint of the patient.
Regarding the patient.
So
Complaint.
symptoms are
Subjective.
Subjective.
subjective. Symptoms are subjective. Signs and laboratory reports which are supporting are objective. Exactly. Okay. So here, swelling of the ankles, pitting to the knees. Okay. Can you please tell me swelling of the ankles understanding? Okay. I can understand that. But what is pitting? Can someone tell me what is pitting edema? Can you define and differentiate normal edema with pitting edema?
Pitting edema is like when we do the observation with the finger, there you can see a pit, and it will come to the normal within some time, not instantly, when you will remove the finger.
Yes. So it is like there is a swelling on the ankle or the peripheral, and when we touch with the finger, when we press with the finger, there is a mark. There is a mark of pressure. There is a mark of pressure, and it comes normal within the seconds or within the minutes. Okay. So that is called pitting edema. There is a pit after the pressure. Okay. There is a pit after the pressure at the edema site. That is called pitting edema. Okay. So there was a pitting edema. And see, JVP plus 4 centimeter. What does it mean, guys? JVP plus 4 centimeter. Anyone?
It's jugular vein pressure, I think.
Yes, that is jugular vein pressure. Definitely. Plus 4 centimeter.
Centimeter, I don't know.
So that is the unit of jugular vein pressure. See, jugular vein pressure, if you can see me here, I told you last time, guys, this is the jugular vein here, from here to here. This is the jugular vein. Actually, both the sides. Usually, we check, in the right side or sometimes in the left side. That's okay. But when jugular veins, are having too much pressure in heart failure patients, usually they are rising. They raise out of the neck, and you can measure them. You can measure the length of jugular vein. How much is it rising? Okay, how much it is rising out of the neck. So we can measure that from here to here, how much centimeter it is. Okay, 1 centimeter, 2 centimeter, 3 centimeter, 4 centimeter. So jugular vein pressure is always in the centimeter, not centimeter to the outside. Okay, not centimeter to the outside of neck, centimeter in the length of jugular vein, which is actually rising outside the neck. Okay, so length of the jugular vein pressure, which you can see, which is visible outside the neck due to high pressure. That is called jugular vein extension. Okay, and that extension is measured in the centimeter. That is in the centimeter. So that is the measurement of jugular vein pressure. Okay, in the centimeter. So jugular vein pressure was 4 centimeter in this patient. It was quite severe. And then,
so, what is the normal JVP? Can I know? I don't
normal
know.
JVP you cannot usually see. I mean, you can just feel with the finger. Usually feel it. You can sense it. You can see just the vein, with the blue. As usually we see the vein. How we differentiate? Arteries are red and veins are slighter blue. So we can see the bluer vein here. We can see the jugular vein, but we cannot find out the extension normally. Okay, usually in the patients of heart failure, we can see the very usual extension. I mean, the extension is really huge, and the extension starts from the dip of the neck, from the starting of the neck, and it goes till sometimes usually it is 6 to 8 centimeters. I mean, the total visibility is 6 to 8 centimeters, but it is in this patient it was 4 centimeter. I mean, it comes out means it is really visible due to pressure, and it has that pulses. Okay, you can feel that pulse there in the vein. Okay.
I have seen the doctors to observe the pulses only, but I have not seen how to measure.
Okay, you must
Only
okay.
here I have seen plus 4 centimeter written.
No. that is you can go and you can ask the doctor, you can ask the cardiologist, and they must be if there are the severe heart failure patients or even the moderate and the heart failure patients with reduced ejection fraction, they usually have the jugular vein pressure. Okay.
Sir, in what
They usually-
other condition JVP will be raised other than heart failure and stroke?
No, stroke patients are not having jugular veins extension.
Okay,
Stroke
sir, what
patients
else?
do not have. Okay.
In
Usually
hypertension also, can we see this?
hypertension
Or not?
also, but hypertension not that great. Okay. Hypertension is not that great. Yes, usually in the severe kidney problems, severe renal insufficiencies, you can see the jugular vein.
Okay.
Yeah. And the patient's weight here is 97 kg.
Sir, then JVP is in minus, I mean negative.
No, I don't think there is JVP in the negative.
Okay.
I never seen. That's never in the negative.
So, sir, there mentioned the positive value. So I thought, is there any negative value?
No. This is like how much extension is there. So this is 4 centimeter plus 4 centimeter, 6 centimeter, 8 centimeter.
Okay, sir.
It's always in the positive because it is extension. Okay.
Yes, sir.
So here weight is 97 kg. Usually the patient's this patient's weight is 85 kg. So what does it say here? What does it direct us to?
The fluid buildup.
Fluid overload. Exactly, fluid overload. So the patient has around 12 kg of the weight which has by just the fluid overload. Okay. And X-ray, cardiomegaly, extension of the heart, basal crackles in both lungs. So the typical signs ECG normal, SpO2 85, almost normal, not that greatly reduced. So first and what are the other supportive measures you will take to diagnose the heart failure in this patient? What are the risk factors? What are the comorbidities or the etiologies of heart failure? Tell me about everything. Let's start with symptoms and signs. I hope it's very easy for you.
Patient
Myocardial
age.
damage. Sir, you
Guys, please put yourself on mute. Put yourself on mute. I went on mute. And I did not know that. I went on mute. Acha, what I was asking is, please tell me about sign and symptoms in this patient. Along with the sign and symptoms, you have to tell me all the risk factors in this patient, and you have to tell me about the etiology of heart failure in this patient. So first, let's start with sign and symptoms. Please tell me the sign and symptoms, complete sign and symptoms, what you have observed in this patient, guys. Tell me. Am I audible now?
Yes, sir. Breathlessness, fatigue, JVP,
Orthopnea
orthopnea,
and alcohol and
fluid
cigarette
overload.
consumption.
No. First, sign and symptoms. No alcohol consumption. First, sign and symptoms. Focus.
Shortness of breath, tiredness, orthopnea.
Okay. So, breathlessness, orthopnea, fatigue. Then come to
And
signs.
in science, anemia is there.
Anemia. Okay. Signs. Anemia.
Pedal edema is there.
Pedal edema is there.
Yes.
Raised JVP is there.
Raised GVP, yes. JVP
Raised
is
JVP
also
is
there.
there. Then
Yes.
Fluid overload.
Fluid overload.
fluid overload is pedal edema.
Basal crackles in lungs, sir.
Yes, basal crackles were there. Basal crackles also were there. Okay. So focus and try to understand, try to differentiate what I'm asking. Try to differentiate in the patient what is sign, what is symptom. Okay. And don't leave anything. Everything is important. When you are analyzing a case, everything is important. Okay, everything. So here in the science, if you look at the science, see, everything I have mentioned very clearly. See, first thing here, if you check in science, swelling of ankles, pitting edema, JVP, and basal crackles. Three signs, three symptoms. Three symptoms. Where are three symptoms? One is shortness of breath, orthopnea, and what is this? Able to approximately walk 20 meters, tiredness, fatigue. Three symptoms, three signs are presently mentioned clearly. Now tell me, what are the risk factors in this patient? Risk factors.
Chronic alcoholic and smoker.
Alcoholic
Smoking.
and smoker.
Ischemic heart disease, hypertension
Ischemic heart disease. Yes.
with MI18.
Myocardial.
That is ischemic heart disease. Myocardial ischemia.
Patient is hypertensive also for past 10
Hypertensive.
years.
Exactly. Hypertension, ischemic heart disease, and
Patient weight.
and you are missing
Hypertension.
hypertension,
MI.
ischemic heart disease, smoking, drinking. Okay. Anything else you are missing, guys? I think you are missing something.
Patient weight is also
Obesity you are missing. You are missing obesity. Obesity is one of the major risk factor for heart failure. Not only heart failure, heart attack, diabetes, hypertension, everything. Obesity is the major risk factor for heart failure. Okay, that you have to tell me in the questions in the group how obesity correlates with heart failure and how it is a risk factor. Okay, so focus now. Medication history. The medication history, the patient was on bisoprolol 5 mg twice daily. Okay, for what?
Hypertension.
Hypertension.
it's a beta
Aspirin-
blocker.
Beta blocker. Okay, for hypertension. Aspirin 75 mg.
Infarction.
IHT.
Blood thinner.
Antiplatelet.
Antiplatelet. Blood thinner is a layman language. You are not the layman, so this is antiplatelet. Okay, aspirin 75 mg is antiplatelet. Okay, okay, now I'll come to the next question. But what is isosorbide nitrate and why it is given? Isosorbide mononitrate 60 mg once daily.
Anti-anginal.
Yeah,
Anti-angina.
Vasodilators.
Vasodilators, anti-angina, both are correct. Okay. Now let's come to the bisoprolol, guys. Okay. Tell me the side effects or the complications of bisoprolol in this patient, if it is possible.
Shortness of breath.
Shortness of breath due to bisoprolol? No.
Hypotension.
Hypotension, exactly. Blood pressure was 105 by 67. So it could be due to bisoprolol hypotension. I mean, see, usually in heart failure patients, we consider lower blood pressure as good. So the blood pressure is okay for the patients of heart failure when we consider it low. Okay, we don't consider high blood pressures for heart failure patients. We always go for the low blood pressures. That's okay. Okay, so that's not exactly hypertension, but blood pressure has the major side effect as hypotension. But I mean the bisoprolol, but these beta blockers are as good as ACE inhibitors and are the first line drug therapies for heart failure, as we have discussed in last class, if you remember. Okay, then I'll not go to the aspirin. Aspirin everyone knows. Okay, aspirin everyone knows. So now tell me, guys, tell me what major side effect of isosorbide nitrate, and what is the precaution? I mean, normally, not in heart failure, not in anywhere. Just I'm asking about isosorbide mononitrate. What is the tolerance? Okay.
Tachycardia.
Tachycardia. What are the problems? What are the major problems? What's the major problem with nitrate?
Headache and hypotension.
Abnormal heart.
Headache. Okay, headache. Dizziness. Usual. Okay, headache. Why it happens? Okay.
Postural hypotension.
Chest pain, sir.
Postural hypotension, chest pain. Okay, but this is usually given for the chest pain only, isosorbide dinitrate. Okay, now can someone tell me why we give isosorbide mononitrate? Someone actually said vasodilator. So what is the exact role of vasodilator in heart failure patients?
Dilating the blood vessels, sir.
Okay, so further?
So that we can decrease the pressure.
So the blood flow is normal.
Blood flow normal. No, I mean yes, correct, but scientific, more scientific.
This is given in view of post MI, as well as it will reduce the preload by venodilation.
Yes, in heart failure patients, what is the exact job of the isosorbide mononitrate?
It decreases volume overload.
Exactly, it increases the
Cardiac output.
no, not cardiac output. It does not increase the cardiac output. It increases the preload and afterload. Okay, now I think these two words are quite new for you. Preload and afterload are a little different from the output. Output usually we measure in case of urine excretion, usually, okay, or we measure the output in case of blood, whatever has come through in a one stroke from the heart. Okay, one stroke from the heart, that is called output. But afterload and preload are like during the heartbeat, how much blood with the pressure is considered to come into the heart in the which atrium? Right atrium. And afterload, how much blood is considered to come to the left ventricle from the left atrium. Okay, that is called preload and afterload. Those are two terms which actually helps our heart to maintain the rhythm and to maintain the circulation of the blood throughout the body. Okay, that is called preload and afterload. So isosorbide nitrate, because this is a vasodilator, so in this, when there is a proper, okay, I think someone's mic is on. Okay, so when we give vasodilators, it maintains, okay, it maintains the blood flow. It maintains the blood flow, and it is, it also reduces the pressure. Exactly, it reduces the pressure, because when we need a good relaxation, okay, when we really need a dilation, we give the vasodilators, and isosorbide dinitrates and mononitrates. They are good vasodilators. And why the chest pain happens? Because there is a less supply of oxygen to the heart walls, to the heart muscles. Okay, so that's why we give vasodilators. So proper blood supply is appearing during each circulation cycle, during each heartbeat. Usually we call afterload and preload. Okay, that is the main job, and that is the main thing, because it dilates the heart, it dilates the veins, it dilates the arteries, and it properly help in circulating the blood. Okay, so now next, now my next question to you guys, what we should add now?
I have a doubt. It's not
yes
clear.
please, yes please, Dr. Vikash.
It's actually in isolation, that is isosorbide dinitrate plus hydrolysis combination is recommended in heart failure, but why this mononitrate alone is not recommended? That's why I my doubt.
That is my question here, Dr. Vikas. My question here is, this is medication history, what we should change and what we should add on. That is my question here. Patient came with the heart failure symptoms. We observed everything. We got sign and symptoms. We got etiology. We got everything, and we got patient is on these medications right now. So
this was the because the patient was MI patient. That's why these medicines. So he was taking.
Yes. So what we should change, and what are your suggestions? What would be your prescription, guys? Tell me about your prescription, then I'll tell what I will add and what exactly was added to this patient. So that is the point of discussion in every case. What is your suggestions? What are your suggestions? What are your drugs? What would be your prescription to our patient now? Tell me. Yes, guys, what would be your prescription? So Dr. Vikas was telling that isosorbide mononitrate could be changed to isosorbide dinitrate and hydrogen in combination. That is called isology. Okay, is it, Dr. Vikas?
Heard you. Sorry.
You were suggesting isologene instead of isosorbide mononitrate.
No. We can, before that we can add AC inhibitor or ARB or ARNI. Then we can increase the dose of beta blocker. Then MRA. Then after that, other required medications.
Okay.
Yeah.
Okay. Good strategy.
Can we add a Lasix?
Okay. For the emergency treatment, definitely we can go for diuretics.
Diuretics and
diuretic drug.
Furosemide 20 mg maybe to start with.
Diabetic drug. Someone told me diabetic drug. Did I hear diabetic drug?
Diuretic.
No, diuretic.
Okay, diuretics. Yes, diuretics. Okay. Other than diuretics. Okay, emergency treatment. Okay, which diuretic you will prefer in this case, guys? Tell me, which diuretic you will prefer? I mean, the normal potassium inhibitors.
Furosemide.
Furosemide. Okay. Can someone tell me what are the different diuretics classes?
Potassium.
Loop diuretics.
Carbonic anhydrous inhibitors. Thiazide diuretics.
With examples. With examples, Fayaz.
Spironolactone.
Thiazides.
Hydrochlorothiazide for thiazides.
Okay.
Furosemide for loop diuretics.
Okay.
Spironolactone for potassium sparing. Acetazolamide for carbonic anhydrous inhibitors.
Perfect. Very good. So loop diuretics we can give. Okay.
Nitinide.
Furosemide. Okay. So
that's it.
okay, that is emergency treatment. Okay, I have given to the patient the Lasix 100 ml. Okay, Lasix 100 mg, sorry, not ml. Lasix 100 mg was given. Patient is now stable. What would be your prescription for this patient now? I mean, after the alleviation of symptoms. Guys, come on.
Sir, nebulizer can be given for shortness of breath.
What is exactly spironolactone's class?
Mineralocorticoid.
Mineralocorticoids inhibitor. Okay. Okay, so let's see the biochemistry results before going to the medications.
Sodium is less.
Sodium 132, potassium 4.3, urea 17.
Level is increased.
Creatinine level is increased. Okay, what should be the normal level for the reference for everyone?
0.5 to 1 point.
1.5
to 1.2.
0.5 to
1.2.
1.2 mg
But
per
sir,
dl.
it's from the baseline.
Sorry?
Sir, 0.2 to 1.2 is from the baseline. And matlab.
Please go ahead. Please go ahead. Complete your sentence. Creatinine is.
Sir, creatinine.
Yes, Heta.
Sir, creatinine
0.5 to 1.5.
Okay, there is a confusion between 1.2 and 1.5. How many are supporting 1.2 and how many are supporting 1.5? What is the right number?
1.2.
1.2. 0.6 to 1.2.
0.6 to 1.2 is the right number. Okay, 0.6 mg per dl to 1.2 is the right number. Okay, is the normal levels of creatinine. Then,
But sir, normal level of creatinine is measured from the baseline. So person to person baseline can be differ.
baseline bole to?
Matlab sir, if like if मतलब पेशेंट्स अगर मसल्स ज्यादा होंगे पेशेंट में तो क्रिएटिनिन लेवल उसका नॉर्मल क्रिएटिनिन लेवल भी ज्यादा होगा.
So you are telling in obese patients?
Yes sir.
Creatinine would be high.
Yes sir.
Yes, sir. Mostly in the sport persons, we consider creatinine level high. Different for sport persons.
I'm not talking about the sports medicines here, guys. Okay, you guys, I think went extreme. That was correct answer though.
Because creatinine is the byproduct of this.
Muscles. That was right answer though, but I'm just talking about the normal patient. This patient, so
it will be very with general also, sir.
Okay.
In this patient, it is not the muscle mass. He is obese. This is the fat only, not the muscle mass.
Okay, so you're telling, okay, now, okay, fine. Okay, fine. I got you guys. So tell me, this creatinine is normal or not?
No.
No,
No.
No.
Okay. Usually, we consider 1.2 mg per dl for kidney problems. For the renal insufficiencies, we consider 1.2. Okay. What you are telling is that is creatinine clearance. If I am not wrong. Okay. That's different part. We can discuss that also. Now tell me, what are the other things here which you think are not in control?
ALP and
AST.
thyroid also, TSH is 5.4. HB12 is also low.
Okay. Okay. HB is low, 12.1. Okay. TSH 5.4. Do you really think that TSH is not normal here? Guys who are not speaking, please put off your mics. Who are not speaking, please put off your mics. Yes, now someone talk. Hello? Hello?
Yes, sir.
Yes, TSH. I think Vikas was talking about TSH. The TSH is high here. Is it?
The normal TSH 0.2 to 2.5 normal patients. I don't know whether this patient is hypothyroid or not, whether taking any medications previously, but this value is little much elevated.
0.2 to 2.4 is normal.
Yeah, 2.5.
Is it someone else?
Zero 0.4 to 4.0.
Okay. So, okay.
It's a normal, I think 0.5 to 5 international unit per liter is normal, I think.
Okay, so tell me the international, national, whatever units, tell me the normal level of TSH, guys. Please tell me the
0.5 to 5
level of TSH. What do you consider? What 0.5 to 5 is normal. Yeah, exactly. So, okay, ALP and ASTs are raised. So,
Raised.
what? Okay, so when do you consider, guys? Okay, so suppose I'm just talking about, you know, AST, ALP, and ALTs. Okay, so here ALP and ASTs are raised. Suppose bilirubin also, we are talking about bilirubin. So when do you consider this is dangerous? When do you consider to be dangerous in the case of ALP, AST, or bilirubin? How many folds higher it must be?
4 times higher than the normal. 4 times.
3 to 5 times higher. 3 to 5 times higher than normal levels are considered to be dangerous or considered to be problematic in any patients. Okay, otherwise we call it at higher level. So here ALP and AST are really high. So, okay, let's see. Creatinine is considerably high. Total cholesterol is also high. What is the normal level of total cholesterol? You must know. It should be on your fingertips. You should not go to the
200.
Google.
200.
200.
Are you talking about total cholesterol or total glycerides? First of all, differentiate.
Triglycerides 150.
150.
So less than 200.
Total cholesterol?
200.
Less than 200. Less than 200.
Triglycerides 150.
Okay, so I think I have mistaken here. No problem. Creatinine is high. ALP, what should be the level, normal level of ALP and AST?
ALP 44 to 46. ALP is less than 270.
45 to 50. 46 to 116.
Yes. Okay. HB is not low. We will not say this patient anemic at all.
Yes.
Okay. This patient is not anemic.
No, only mild.
It's
Yes, sir,
just
not anemic.
mild. Yes, that is on the lower level. Okay. It is just on the lower level, not anemic. Fine. Now tell me the provisional diagnosis of this patient. Provisional diagnosis means including all the diagnosis, including all the conditions the patient has. For this patient, tell me the provisional diagnosis, guys. Yes, guys. You have sign and symptoms, you have comorbidities, you have medicines, lab checks, everything with you. Now tell me the provisional diagnosis of this patient.
Heart failure.
Hepatomegaly, sir.
Sir, is there any finding on the ECGs to make it more?
Patient is on heart failure.
That's why I'm asking provisional diagnosis. I'm not confirming. Confirmation, I will come to that question. Wait, I'll come to that question.
Patient is on active heart failure.
Okay, heart failure.
Pulmonary edema.
Pulmonary edema. Yeah.
With AKI.
Then reduced renal perfusion, reduced liver perfusion.
Okay. Guys, come on. Provisional diagnosis.
Pulmonary edema with acute kidney injury.
COPD.
CCF with AKI.
Possibility of LVH also.
Sir, chronic obstructive pulmonary disease.
So it may be CAD with unstable angina, acute coronary syndrome, like that.
Congestive heart failure. That's correct. Acute congestive heart failure. Post CAD, congestive heart failure or acute heart failure.
Yeah, CAD. Or it can be acute decompensated heart failure.
Okay, perfect. CHF. Sorry, I think today I'm suffering with a bad network, guys. Bad network. I'm so sorry. Okay, so what are your final diagnosis? Pulmonary hypertension. Ansika, on what basis you are telling pulmonary hypertension?
CCF with AKI.
What is that?
CAD with pulmonary edema.
Pulmonary edema is not there. By the way, on what basis you are telling pulmonary edema? Tell me. Because the patient was
crackle sound in lungs, sir.
What?
Cardiomegaly and crackle sound in both lungs.
Basal lung crackle sound.
Yes, basal crackles were there, of course, and there are the high chances of pulmonary edema, definitely, because there is cardiomegaly and breathlessness and excessive fluid overload. Okay, excessive fluid overload. So there are chances of pulmonary edema, but see that acute heart failure, when we are talking, that considered the pulmonary edema as well, because acute heart failure is also called as decompensated heart failure, in that it is actually consists the pulmonary edema. Okay, and congestion. Okay, congestion and pulmonary edema. So acute heart failure, that could be the provisional diagnosis. And hypertension, definitely ischemic heart disease, because patient is myocardial infarction. And other discrepancies to keep in mind, it could be raised LFC, LFTs, liver function test for evaluation. Okay, so this could be the provisional diagnosis. What else did I leave here? Anything left, guys?
AKI left, sir.
Okay. Acute kidney injury.
This is see other discrepancies to keep in mind. See, look at this. Raised LFTs. This could be AKI. Okay, this could be AKI. So when we exactly diagnose the AKI, can we say at 1.6 Creatinine.
No, sir, but because urea is in the range.
Yes.
No, sir. It should be at least
Yes.
threefold increase from the baseline.
Okay, it should be it should be at least more than 2.4 creatinine, and AKI is not only considered based on the creatinine, it is based on the creatinine clearance. Okay, GFR, right? Based on GFR we call it AKI, or okay, so that is the provisional
This
diagnosis.
patient can have any liver problems as well, because he is a chronic alcoholic and his these LFTs are also
Yes,
like abnormal.
yes, this patient can have, definitely this patient can have liver problems, but as I told you, if these things are not more than 3 to 5 folds, we do not look into, usually, I mean, that is the practice. Usually we do not look into those things which are, really, in case of liver enzymes,
So we
SGPOT and
can say he is
SGOTs,
at risk.
he's at risk. Yes, definitely he's at risk. He is at risk. Okay, so now let's go for the further tests to confirm the diagnosis. So now my question is, what are the other tests we can do to confirm our provisional diagnosis?
2D echo.
ECG.
Echocardiogram.
2D echo.
2D echo.
2D echo. And
Echocardiogram, BNP.
BNP. Perfect. Okay, so 2D echo, normal wall motions. Normal wall motions means, what does it mean by normal wall motions here? Anyone who tell me what does it mean by normal wall motion at this point of time? I'm giving a clue. Whatever. Normal wall motions at this point of time, if it is normal wall motion, what does it mean in this patient?
Contractions and relaxations.
Mitral wall and vital speed wall.
The heart has compensated for the heart failure.
Myocardial wall is normal.
That means
Ejection
there
fraction.
is no new infarction. Okay, normal wall motions means there is no new infarctions. Understand? Wall motions, this is wall motions, not valve, not VAL. Talking about wall motion, the wall. Okay, usually we go for the wall motions when the patient gets infarction. Okay, in that case we see that global hypokinesia. Global hypokinesia means there is no wall motion at all, because there is no oxygen supply at all. There are multiple things. Okay, so in this case, no wall motion means there is no new ischemia. Okay, no new ischemia in this patient. Mild diastolic dysfunction. Okay, normal, mild diastolic dysfunction, but left ventricular ejection fraction is 34%. 34% means which category of heart failure?
Reduced ejection fraction. Reduced ejection fraction.
Reduced ejection fraction. HFR.
Yes, today my connections are poor. Definitely my connection is poor, Shankar. Thank you for letting me know, but it is poor, and I got disconnected many times. So I'm going to change this Airtel. Definitely. Okay. Yes. So this is heart failure with reduced ejection fraction. Yes. So what should be the criteria for that?
Ejection fraction less than 40%, sir.
40.
Exactly. Okay. So this is LV systolic dysfunction. The left ventricular ejection fraction is less than 34. Next test would be troponin T is 0.079. Anti-proBNP is 1672 picogram per ml, and troponin T is 0.079 ng per ml. So can someone tell me if the troponin T is normal? And what is the normal limit of troponin T? Am I not audible clearly? Okay, that would help, I think. Okay. Now, what is the normal limit of troponin T? 0.
Less than 0.01.
0 to 0.4 nanograms.
Just tell me if it is normal or high.
It's normal.
Elevated.
It's elevated.
It's elevated.
Elevated.
It's elevated. According to the book, it is elevated. Okay, because it should be less than 0.01 ng per ml. But in the cardiac practice, in the cardiology practice, this is normal. We go for 10 times higher. If it is not 10 times higher than normal, we don't consider it. Why we don't consider it? Because of the underlying causes here. Underlying causes are renal insufficiency and heart failure. Okay, pedal edema. Multiple things are there, and hypertension. In this case, obese patient. So it must be 10 times higher, then only we will consider it for infarction. So here it is normal for infarction. Usually we go for, in our practice, normally also we go for the, when we consider it for heart attack or the infarction, any kind of myocardial infarction, we consider it more than 0.1. 0.1. So this is absolutely like normal right now. Okay, this is normal. By book, by law, it is raised, it is high. Okay, but usually in the practice, evidence-based medicine, we usually consider the troponin T higher when it is more than 0.1 nanogram per ml. Okay, now let's talk about the N-terminal pro-brain natriuretic peptide, NT-proBNP. How much it is? How much it should be?
Less than 100.
It should be 300 per
Less
ml.
than 300.
Less than 300. It should be less than 300. Definitely, considering all other comorbidities, it should be less than 300. Otherwise, it should be less than 150 in normal healthy people. In this patients, we can consider it less than 300, but it is far away than that. It is quite higher, 1672. So it confirms that our patient has the heart failure.
Sir, I have a doubt.
Yes, please.
Yeah, there is two tests that are BNP as well as NT-proBNP. In case of BNP, it's more than 300 is recognized diseased persons. But in case of NT-proBNP, what is the difference in the normal level when comparing to BNP?
No. In case of BNP, it is 100 picogram per ml. In case of NT-proBNP, it must be less than 150. Okay, BNP 100, NT-proBNP 150. Usually in the healthy person.
Okay.
Yes,
okay.
less than 150, 100 and 150. Okay. Yeah. Okay, so this is quite higher. And now what could be the final diagnosis? Let's see the final diagnosis. Final diagnosis is acute heart failure. Acute heart failure with systolic heart failure, left ventricular ejection fraction 34. Left ventricular ejection fraction 34. And then what else should be? Yes, guys, what next in final diagnosis?
Hypertension.
Yes, hypertension and
IHD, ischemic heart disease.
Ischemic heart disease. Yes. So acute heart failure or heart failure with reduced ejection fraction, hypertension, IHD, old MI. This was the final diagnosis. Now, this is the best question, and I love this question always. What could be the differential diagnosis here? And before going to the differential diagnosis, who can tell me what is the differential diagnosis mean? Yes, please. Guys.
Final diagnosis.
Differential diagnosis usually means the underlying causes, like it can be kind of subjective.
No.
Like they could be an like for example, usually we see in the impression of the reports, like it may be neoplastic or there may be some carcinogenic properties to it. I'm giving an example, I'm not talking about this case.
Okay, so here I have the interesting and right answers in the chat. Ruling out other possibilities of the disease, or exactly the plausible diagnosis of the same signs and symptoms. That is the right definite answer for that. Actually, the differential diagnosis means the other problems which mimic the same problem which is existed right now. Okay, the other conditions which can mimic the present condition. Am I audible, guys? Vikas is writing, cannot hear you.
Yes, sir, you're audible.
Okay, so the conditions which can mimic the original problem or original disease are called as differential diagnosis. Okay, so what are the differential diagnosis means here? No, it cannot be confounding factors at all. No, not confounding factors. No. So what are the differential diagnosis for this patient, guys? Please tell me fast.
DCMP, dilated cardiac myopathy.
Dilated cardiac myopathy. Okay.
CAD,
DCM, okay. Coronary artery disease. Okay.
COPD, sir.
COPD. Yes, COPD. Then. Okay, let's list out. Tell me the major and minor. Okay. Bronchial asthma. Exact sign and symptoms as heart failure. COPD, major differential diagnosis for heart failure. Then mitral regurgitation or any valvular heart disease. They show the similar sign and symptoms, even the pedal edema sometimes. Okay. Then restrictive cardiomyopathies, pulmonary thrombosis, critical MI with pulmonary edema, anemia. Anemia could show fatigue, anemia could show breathlessness, okay, and hypertensive emergencies. So you understand, guys? You understand here? Bronchial asthma, COPD, HOCM, yes, HOCM could be. So here I'm talking about restrictive cardiomyopathy. So yeah, it could be one of that. Okay, so bronchial asthma, COPD, mitral regurgitation, or any valvular heart disease, restrictive cardiomyopathies. You talk about restrictive cardiomyopathies, guys, and tell me in the next class what is restrictive cardiomyopathies. Okay, pulmonary thrombosis, critical MI with pulmonary edema can mimic the same symptoms, anemia, and hypertensive emergency. Okay, then we have discussed all subjective, objective, assessment, and what is P? So F analysis.
Planning.
What is SOAP means?
Subjective assessment and planning.
And F? F means what? Okay. Subjective means sign and symptoms, we did. Objective means medical, medication, family history. Assessment, lab investigations, imaging, radiology, whatever is then. Problem list. Planning, follow-up. Okay. Follow-up is very important in any case. Okay. Follow-up means it does not mean that it is you have to follow the patient for 1 year or 2 years. It is when you are going to see the patient, maybe this would be the first day or the second day of the patient in the hospital. So you have to follow for the outcomes at least until the patient get discharged from the hospital. Okay. So now initial treatment after provisional diagnosis. Aspirin 75 mg was there because the patient is having the ischemic heart disease. Shifted to CCU, cardiac care unit, and started on oxygen support by NIV. What is NIV?
Non-invasive ventilator.
What is non-invasive ventilation?
Without
So the
cutting
CPAP and BiPAP.
Without
Any intubation. Without intubating the patient.
okay, correct. So NIV, aspirin, furosemide, perfectly you said, furosemide 40, one stat, and every 6 hours till the symptoms improve.
Maybe
Okay.
100 only, sir. How can we do?
Okay, you're right, but based on the potassium and sodium was just 132 of this patient, if you remember. Okay, sodium was 132, potassium was 4.1 or 3.9, I don't remember. Let's see what was the potassium. Based on that, we gave 40 mg and the frequent doses. Okay, see
4.3.
yeah, 4.3, and sodium was just 132. So we have to consider all the biochemical results also. Based on that, we have to find out the dose of diuretics. Okay, otherwise patient will directly go into the sodium depletion immediately. Okay, so we have to consider those things, and then we have to give the dose. Then we have to decide the dose of diuretic. So diuretic dose of 40 mg was given stat, and every 6 hours till the symptoms improve. Remember this. You should not see that, okay, patient has a lot of symptoms, patient is not breathing, so give 200 mg furosemide. No, not at all. You have to look into the biochemical parameters. You have to look towards the sodium, potassium, creatinine, renal insufficiency, renal problems, and then decide the dose of diuretics, because diuretics are directly working on your excretion system, your kidney. Understand?
Sir, can we give continuous infusion of furosemide?
Continuous infusion in this patient was not needed, definitely. I feel why it was not needed, because patient had the acute heart failure, and we did not know the exact pathophysiology of this patient. It could be due to myocardial infarction, and first we have to see for a few hours, we have to observe the patient, how patient is behaving to the diuretics. So direct we cannot usually start with the bolus or bolus or IV. Usually the infusion we usually give the IV, and then we see, we look for the symptoms for some time, and then if it is not improving, if the symptoms are not in control, if the patient is not reviving to those doses, or then we decide for the bolus or something, usually in the heart failure patients.
Okay.
Yeah. Then bisoprolol 5 mg once daily in the morning. It was reduced. What was the dose before?
5 mg BD.
5 mg BD. Yes. So bisoprolol was cut down to once only, and then enalapril was added. Now tell me, guys, why bisoprolol was cut down and enalapril was added?
Now, enalapril has the class 1 recommendation to start for the heart failure patient, and
Exactly.
bisoprolol is recommended only once daily regimen in heart failure.
I mean, it's not like that. It is recommended only once daily, but the thing here is the patient was at the side of hypotension also. Patient's BP was 105, and bisoprolol is not alone recommended as a first line therapy for heart failure. So the first line therapy of heart failure is ACE inhibitors or ARB if ACE inhibitors are not what we say, tolerated by the patient. So enalapril was the first line therapy for heart failure along with the bisoprolol, and patient is hypertensive but at the side of hypotension. So the patient was started with just the lower dose of enalapril 2.5, and even the bisoprolol was cut down to 5 mg. So this is the right combination as a first line therapy for heart failure, beta blocker and ACE inhibitors, starting with the lower dose. Considering other factors, MI and hypertension, we started with 5 mg of bisoprolol and enalapril 2.5 mg, along with furosemide is also there. Okay, remember that furosemide is also there. That is also working for the hypertension. That is also, you know, kind of a vasodilator, or not vasodilator. I'm so sorry. That is that is also one antihypertensive medicine. And for the heart failure, we are giving for the heart failure to reduce the fluid overload. So these all things are considerably, given together, because patient is in acute phase right now. So not only furosemide, but along with furosemide, bisoprolol and enalapril. Enalapril was newly introduced along with bisoprolol, lower dose. Okay, so this was the discharge prescription at the end. Enalapril was raised to 5 mg. Furosemide was cut down to 40 mg only one day. 40 mg once in a day, but half, 20 mg, 20 mg. Okay, and only for 5 days. Atorvastatin was added because the patient is, why atorvastatin was added here, guys? Tell me.
Because the patient was obese.
Obese and total cholesterol.
Total cholesterol, because of
Cholesterol
total
level is high.
No. Cholesterol level was not high. Total cholesterol was normal. See, why atorvastatin was introduced? Because that is the recommended therapy for myocardial infarction, and it was not there in the prescriptions before. First consideration. Okay, second consideration, the patient has hypertension and myocardial infarction. The patient has two risk factors, and now the patient also got heart failure. Okay, and patient is already obese. So again, there are the chances of reinfarction. So atorvastatin was mandatory to given as dual what we call it, triple therapy.
Why not preferred in combination,
along with what? Sorry.
Why not preferred in combination, sir? Ecosprin, AV.
We can definitely give ecosprin AV. That's okay. See, here we are talking about the different medicines. It might be given in the combination also. That's okay. We can give in the combination also. Okay, we can give in the combination. That's okay. That's not a problem. But I think 75/20 is not available. 75/10 is available. Ecosprin AV, if I'm not wrong. Okay, that is one thing. Now justify ivabradine, guys.
Patient heart rate was high. I think heart rate was high as well as BP is low, so unable to continue the bisoprolol. Then it was discontinued and increased the enalapril dose and added ivabradine.
Exactly. The reason, patient's BP was at the lower side. Patient was not tolerating dual antihypertensives, though they are recommended for, these are recommended for heart failure, but patient also was towards the hypotension, and patient's heart rate was 97. If you remember, patient's heart rate was 97. So ivabradine is the best choice to control heart rate and heart failure together, other than instead of bisoprolol. So that's why bisoprolol was cut down and ivabradine was added along with the higher dose of enalapril, right? And then pantoprazole for a few days till next follow-up. Why pantoprazole? Usually we give, usually that is the tradition, but scientifically we give with aspirin, because aspirin is known for generating gastritis. Okay, so that was the discharge prescription. Now we are done with this. Any doubt till now? If not, then what would you suggest the patient to take care at home? What would be your counseling to a heart failure patient? Tell me, guys.
Monitor the BP as well as intake output. Then along with
water intake, sir.
Yeah, along with that serum electrolytes measurements, I think it will be done
How
After five-
frequent? How frequent?
After the initial 3rd day and the next 7th day.
Water intake
Okay.
restrictions, sir.
So,
General. Yes, Aisha.
yes, sir, you just said this. Ivabradine is added because the patient didn't tolerate diuretics. Is that, or
No, I did not
Can
say
you
that
just-
patient did not tolerate furosemide.
can you
I
just
told
explain
patient,
again
Bisoprolol.
why Ivabradine was added and Bristol was
patient could not tolerate dual antihypertensives. I told patient could not tolerate dual antihypertensives because his blood pressure was towards the hypotension 105/67. So patient was continuously at the lower side of blood pressure. So we discontinued bisoprolol. And another consideration to discontinue bisoprolol and introduce ivabradine, because ivabradine, maintains the heart rate also. Okay, maintains the heart rate also, and it will not affect on the central sympathetic system, which is directly connected to the blood pressure. Okay, if you read that RAS system, so the ivabradine is not directly intervening with the blood pressure, so it is not causing hypotension as bisoprolol was doing. So that's why bisoprolol was cut down and ivabradine was introduced to control the heart rate and not to intervene with the blood pressure. These were the two reasons. And enalapril was raised to 5 mg because enalapril is the first line therapy, definitely. Okay, so it was given, and furosemide was given only for 5 days, right?
Okay, sir, thank you, got it.
So why furosemide is only recommended for 5 days and discontinued?
Because patient was now patient's sign and symptoms were in control. Patient's fluid overload was completely recovered. Patient had no pedal edema. Patient had no sign and symptoms. So furosemide, if we are giving continuously 40 mg or anything, because the patient was in acute heart failure and patient was recovered well, so we should not continue the furosemide for the longer time. Otherwise it will again has an impact on the kidney, has the impact on the renal parameters. So that's why we have the other medications like enalapril and ivabradine right now. So we ask the patient to come up after 30 days with these, and then or the patient has the symptoms or some kind of any other problems, then the patient can come. But right now that was the the best choice not to continue. Usually we do not continue furosemide. Furosemide continuation for long term are recommended, actually is recommended in case of chronic heart failure, not in the acute heart failure or not in the early phase of heart failure. Otherwise it has an impact. It has an impact on the kidney, and not only the kidney, but it has the impact on the cellular what we say here. I forgot the term. Actually, there's a term actually on the RAS system. So we should not consider in the early phases of heart failure, we should not consider the diuretics for long term.
Okay.
Yeah. Then now patient's education. Yes, patient's education is important. Okay, and what is the patient education? Explanation about heart failure. What is the trajectory of heart failure? And medication treatment, how medications are important, why it should be given daily, why it should not be skipped, because if the patient is skipping any medicines, then the comorbidities or the heart failure symptoms can raise up, okay, can come up or can exacerbate. So that's why we have to tell the patient about the heart failure and the trajectory of heart failure and the medications and the benefits of medication compliance. Okay, then if there are any implanted devices, we have to tell them. And then activities and exercise, very importantly, lifestyle modification is very important. So to undertake the regular exercises and be physically active, to be able to adapt the physical activities to symptoms, status and personal circumstances. That means the patient has to improve the lifestyle, improve the quality of life. Okay, quality of life by the tailored exercises or tailored activities. Okay, Then sleep and breathing exercises are recommended. Okay, those are very, very important. And then the fluids. What is the average fluid? How much fluid we should give to the heart failure patient? Can someone tell me? Don't tell me that it's 1.5 to 2 liters per day as it is written. Usually in the normal practice, how do we consider?
The less the
Yes,
better.
please. Sorry? I think
1.5
someone-
times of
1.5 times.
Yes, absolutely. So it should be 1.5 of the previous day's urine output. Okay. If the patient's overall urine output is 1 liter, then next day the patient can take 1.5 liter water. If the patient's urine output is 2 liter today, then patient can take 3 liters of fluid, not water, fluid, total fluid, including chai, coffee, or water, everything. Okay, so the fluid intake depends on the urine output. You have to be very much cautious about the measurement of urine output of the patient, and then you should go for it. And then healthy diet means the salt intakes must be restricted in heart failure patients. Salt intake must be restricted. Patients should not go to the malnutrition, but avoid excessive salt intake. Okay, definitely not higher salt intake are recommended at all. Okay, then alcohol and smoking are totally restricted, must be, because it can exacerbate the symptoms. Immunization, to be aware of the need of immunization of influenza and pneumococcal disease. As I told you, I think in starting also, in vaccinations are important in heart failure patients because they are more prone to get influenza usually and pneumonia symptoms. And then it will restrict your treatment pattern, because first of all, you will not understand what is the symptom of exactly. Okay, if it is heart failure or pneumonia, okay, there will be the chances of infections, and due to infections, the exacerbation of heart failure. So we always have to immunize the patient, immunize the heart failure patients, usually the severe conditions. Usually the patients with heart failure with reduced ejection fraction, we should always give them immunization every year for influenza and pneumonia. Okay, then smoking and other drugs restrictions. Travel, leisure, and driving, of course, that should be restricted, because we don't know what time in travel and driving they have to exert themselves during the exercise or during the driving. So they push the limits. Usually we should not give them too much, but always we should be prepared for these things, travel, leisure, and driving. Okay, and symptom monitoring, definitely. And some psychological issues are there, because always patients think that I'm going to die. Okay, I'm going to die because I'm not fit. I am creating burden to the family. If they have signs and symptoms, they are not able to do their personal activities, they're not able to do their proper activities, daily activities. So they think they get the psychological issues. The depression and anxiety is the major issue in heart failure patients. More than 50% patients of the heart failure get these psychological issues, the depression, because they feel that they are the burden on the family. Because of them the financial crisis, the finances are going, and because of them there are multiple things, they cannot live their proper life. So multiple things are there, so they usually go to the depression. And in such patients, we should always keep them motivated, always keep them out of these conditions. Okay, so that's all for today's case. I took these references from the 2021 ESC guidelines for the diagnosis and treatment of acute and chronic heart failure. If you get the time, please read that. These are freely available. You can download from the ESC website, European Society of Cardiology website. Please read that. Okay. And then 2017 ACC, AHA, FSCA focused update guidelines for management of heart failure. These are American College of Cardiology guidelines 2017. And then these are the Indian guidelines, CSI position statement. These are actually the copy paste from the European Society of Cardiology. But you can read, if you want to read in the short and crisp guidelines, you can go for the Cardiological Society of India position statement of management of heart failure in India. And these are the things, guys. So thank you very much for today's class, and you have nicely contributed, guys. So any question now?
Sir, patient is chronic alcoholic, sir. We didn't keep any medication regarding alcohol during in admission after also discharge.
No, we did not give the medications for for the alcoholic condition. But in this case, we can, we had to suggest the patient to leave the alcohol. We had to counsel the patient for, alcohols, to stop the alcohol and to, for the smoking cessation. But it's not necessary to give the medications from the starting. It is like, when the patient are, not considering our counseling, then we have to go for it. Otherwise, it's not necessary to give these drugs for the alcohol and all immediately.
Even withdrawal symptoms will not.
Sir, withdrawal symptoms.
I mean, see, I mean, directly we cannot tell them to stop, but we can definitely see, we can suggest them to stop. I'm very sure that Indian patients are not, very happy with the suggestions, and they do not consider our suggestions properly. So, if we tell them like to stop, they will definitely not stop. They will, taper the alcoholism. Maybe they will not take once in a month, but they will, they will not take, daily, but they will take once in a week. Okay. Usually it happens. I'm just, not kidding, it is true. But usually we can suggest them like, okay, you can cut down the alcohol, you can cut down with the cigarettes, and then you can stop a day, and sometimes. So that's there.
Prior to, similarly, prior to discharge, the investigations can be repeated in order to check whether they are came.
I think these things were repeated. And I mean, I'm not having these here, but I believe everything was normal. Everything was normal. I mean, normal means the anti-protein P was somewhere around 600, if I remember, and creatinine was somewhere around 1.4, and the patient's other parameters were normal. I think everything was almost, proper. So that was the acute heart failure. So we could. Yes, Anna.
So regarding the alcohol, are we not even giving vitamin B12 in this start, sir? Just for a.
Sorry.
Are we not even giving vitamin B12?
No need. See why it is necessary right now.
In chronic alcoholism, thiamine deficiency will arise.
See, there was no deficiency. Vitamin B12 or other deficiencies were checked. Those were not there. Okay, those were not there definitely. And the patient will not go to withdrawal symptoms immediately. I'm very sure because the patient has to follow after 30 days, within 30 days to as it was. But you see usually immediately when you are telling the patient, okay, you have to leave the alcohol, and you should not immediately give the other drugs. Okay, like, okay, patient is going to leave immediately, and patient will go to the withdrawal symptoms. Withdrawal symptoms are not in the 100% patients. Okay, so first of all, withdrawal symptoms are not seen in all the patients who are withdrawing from the alcohol. Okay, there is a very less percentage. Withdrawal symptoms are seen, I think, less than in less than 50% of the patients, if I'm not wrong. Check it out and please let me know, correct me if I'm wrong here. So withdrawal symptoms, you cannot immediately start the withdrawal medications, even if the patient is leaving the alcohol completely, because every patient does not get the withdrawal symptoms.
So suppose the sodium level is very low, like below 125. So do we first do the sodium correction and then go to sclerosamide in the initial treatment?
If the sodium levels are very low, then we definitely start with the sodium bicarbonate. We definitely start with the sodium bicarbonate in such patients.
Can I ask one question? In that case, can we give a 3% saline instead of sodium bicarbonate?
Okay, saline can be given. Saline was actually given to this patient for some time, but excessive saline is not recommended because of the fluid overload. But I think, see, this patient was not in that condition, frankly, where he was, because his renal parameters were not that degraded. I really feel. But for your questions, yes, it can be given at the lower rate. At the lower rate, it can be given. Not the 400 or 200 ml per hour, but we can start with 50 ml per hour. In such patients, we give.
Okay. Thank you.
Yeah. Okay, guys. So we can clear these doubts later because I think another session has been started.
Okay.
I have to join that. Okay. Take care, guys. See you. Bye bye.
Thank you for the day.
Thank you very much, guys. Thank you.